heard from the first three talks that there's a lot of complexity here, and I'm sure there'll be a lot of questions. We are planning through the Institute for Prostate Cancer Research to open a prevention clinic where individuals that think they may be at risk can come for advice regarding screening. Family members of those diagnosed with prostate cancer that may think there's a family risk can come for advice and genetic counseling and genetic screening. And those worried about recurrence can come and talk about lifestyle changes and things. So this should be open up in about 1 to 2 months. It'll be over at Roosevelt at the University of Washington. And for those of you interested in that, just let us know. So you've heard a lot about issues related to screening and diagnosing prostate cancer. For many types of cancer, we use imaging. For example, mammography for breast cancer. That's been extraordinarily difficult for prostate cancer. Evan Yu, our next speaker, is a medical oncologist who's been quite interested in innovative approaches to use imaging for monitoring prostate cancer both locally as well as once it's spread. And so he's going to give us a discussion about that. Evan?
Thanks so much, Pete, and appreciate you all being here today. It's obviously a beautiful day outside, so look forward to that walk after we get done with this symposium here. So I will talk about imaging, and I'm going to focus a lot on PET imaging. I think many of you know that standard imaging for prostate cancer are doing CAT scans, which give you kind of an anatomic picture of what things look like. There are also bone scans, which kind of look for cancer in the bones, but they don't really look for cancer in the bones. They look for kind of abnormal uptake in the bones, and anything can look abnormal on a bone scan: arthritis, trauma, fracture, anything like that. So we've started doing some research with PET imaging and PET CT imaging combined together. And I think the advantage to doing PET imaging is, you see the picture of a patient there in the PET CT imager, is that it really combines two different types of imaging. It gives you an anatomic picture of what things look like, but it also gives you a molecular picture, a metabolic picture. So the whole idea is you can actually give a quantifiable measure of what's actually happening in the tumor. And there's all different types of radiotracers that we can inject into the patient, and they image different things. So for instance, we can image glucose metabolism, we can image lipid metabolism. We're even able to image certain things like proteins, like the androgen receptor, etc. So there's a lot of different things that can be looked at. And also we're able to actually measure exactly how active things are. So that's the point of quantitative, is that you don't just get is it there or is it not there? You get a measurement as to how active is it that's there, a numerical measurement. Another thing that's very important is that if you think about what we use with prostate cancer patients now, I mean, Jonathan just talked nicely about PSA, but PSA is really kind of a broad tumor marker. It's a sum of what's happening in the body. It's kind of all added up together. It doesn't give you any specific information about any anatomic site. And many of you may also know that we have a very robust tumor biopsy program now, where we're not just biopsying tissue in the prostate, but we're actually taking cancer from metastases, tumors that have spread. The challenge with that is that a lot of work's been done, especially in this group here, that shows something called heterogeneity in prostate cancer. And what that means is that we all know that the behavior of one person's prostate cancer may not be exactly like the behavior of the next guy's prostate cancer. But the surprising thing is that even within one person's own body, one side of the cancer in a bone versus another side in another bone may behave very differently and may have genetic characteristics that are very different as well. And so that's an advantage that PET CT imaging can do, is it can show you potential differences there. So I'm just going to talk about a few different reasons why we would do PET CT imaging. The first one is just to find the cancer. So one reason is, you have high risk, potentially prostate cancer. You might have had surgery. The PSA might have come back up. And the question is, can we find the cancer where it's at now? Can we still potentially cure it? Can we take it out? Is it in a lymph node somewhere? Can we do radiation or surgery to potentially cure it? Another reason is that, maybe you have high-risk prostate cancer and you're thinking about undergoing surgery or radiation or some potentially more invasive procedure, and you want to know, is this a worthwhile procedure to undergo? Might we find the cancer somewhere else, like in the bones, where unfortunately it's too late to cure the disease, but we still can use many, many life-prolonging therapies with hormonal agents. There's a lot of new therapies out there that have recently been FDA approved, but saving the patient from undergoing an unnecessary procedure that might not cure the patient. So I'm just going to cut to the chase with what the best imaging agents are, PET imaging agents we think are for imaging lymph nodes, for imaging bone. I'll start with the lymph nodes. There's been a lot of data recently on choline. We've done some work with acetate as well. And you might ask, what are these agents that we inject into the patient? Well, they're radio-labeled components that are really important for the cell membrane, for the tumor cell membrane. This is important for division of the membrane to basically form the surrounding of the cell and keep the internal contents contained. So this is imaging lipid metabolism with agents like choline or acetate. And the other advantage is that we've been using a cyclotron that we have here, which allows us to generate the radio tracer right on site. We are able to generate C11 radio tracer, which is different than what's standardly used for PET imaging you may have heard of for other cancers with 18F. That's a fluoride-based radio tracer that's excreted via the kidneys, via the bladder. That has challenges. It has a much longer half-life, hangs around a lot longer, and can kind of obscure the pelvic region where we're trying to look at those lymph nodes. This gets broken down into C11 CO2 and gets breathed out via the lungs, and so you're able to really visualize the pelvic region very clearly. And we know that the standard PET radio tracer, which is 18F FDG, which images glucose metabolism, tends not to be as sensitive or able to pick up prostate cancer as well as some of these other new imaging modalities. So this is the largest series of C11 choline. There's a lot of smaller series. I just wanted to pick the largest one. This was over 2,100 patients. And what they wanted to focus in on are patients that underwent prior surgery, radical prostatectomy, and had biochemical recurrence. That means the PSA started to come up. And in those patients, 358 qualified, they found that 45% of them had a positive PET CT scan. They found cancer in the lymph nodes, in the bed where the prostate lives, and 29% in the bone. And as you can see here, this is basically the prostate bed. Here are lymph nodes. This is bone. And so the whole idea is that this imaging seems to be very sensitive or capable of picking up the cancer, perhaps much better than some of our standard imaging modalities out there. But what they did find is that the mean PSA, the average PSA for the patient that had a positive choline PET scan, was 3.7, and the median, meaning you line 100 guys up in a room, and how high that PSA was for the 50th percentile, right in the middle, was 1.27. What this graphic here shows is that based on what your PSA is, what percentage of those patients had a positive choline PET. So obviously those with lower PSAs had a smaller percentage with positive choline PETs. But once you get up to the 1.5 to 2 range, about half the patients had a positive choline PET scan. What about acetate? Many people have asked about acetate. It's, again, very similar in the fact that it images lipid metabolism. We've done some work here. Much of the work was initiated here early on by Bruce Montgomery and Janet Urian. This is just a picture of how nice it is. It's able to show a lymph node here, but it's also able to show the prostate there very nicely. Now, it's not the best at delineating what's in the prostate. Is it good at delineating what's BPH, what's high-grade PIN, what's prostate cancer? But you can see the advantage that C11 radio tracers have here in the fact that if you had a patient get 18F, it's a radio tracer that obscures, it's excreted into the kidneys and the bladder, and this whole area would look blacked out there. That's not all cancer, that's just a radio tracer living there. So again, and this just shows some of the early work with acetate. So you might ask, what's the verdict? Choline or acetate? There have been more studies with choline, but both really perform in a pretty similar manner. There just hasn't been quite as much work published with acetate, although there's an increasing amount of publications there. Neither is really adequate for the primary tumor, as I mentioned, because the limits of detection are about 5 millimeters, and it's not able to differentiate all the other different pathologies that could occur in the prostate, like chronic inflammation, prostatitis, those sorts of things. But for lymph node staging, we know that choline has very high specificity, ability to pick up the cancer, and acetate performs similarly. So we need to really demonstrate the impact of what it has when we respond to these PET imaging studies. So if you have a positive imaging study and you do surgery to remove those lymph nodes, what happens down the road? Is that intervention something that makes a difference? We don't quite know that. We've certainly had anecdotal cases where we started to respond to this. And there's limited number of treatment response studies. So this is basically looking at bone now. So I'll show you that basically the best imaging modality for bone is probably sodium fluoride PET. These are standard bone scans. This is what we're doing. This is SPECT, which is like a 3D bone scan. And as you can see here on the same patient, you can pick up a lot more cancer with sodium fluoride PET. What's the advantages? This is a small molecule. It's rapidly cleared. You can image very early. It's commercially available and FDA approved. It's more sensitive than standard bone scan imaging or the standard FDG glucose metabolism PET. And when you combine it with CT scan, it increases specificity. So one might ask, if it's so sensitive, how much earlier can you pick up a metastasis with sodium fluoride PET versus a standard bone scan? There haven't been well-done studies looking at that, but I can show you an anecdotal example because we've started using this clinically. This is a patient who you can see here about a year and 3 months or so. It took about a year and 3 months before the cancer was clearly evident on a bone scan in a couple different places there. This patient had very high-risk localized disease and was thinking about undergoing surgery, radical prostatectomy. Here, back about a year and 3 months before that scan showed cancer, we could actually see the tumor in the PET CT in both locations here. So this was able to save the patient from undergoing a curative surgery, which unfortunately would not have been curative because the cancer had already spread. It's just that our standard imaging was not able to pick it up. So I want to talk about the second part of the talk, which is not just finding the cancer, but how about measuring treatment response in the bone? It's very hard to quantify what's happening in the bone when there's cancer in the bone because what you're measuring bone scans is just bone turnover. It's not cancer activity. So what we're able to do basically is use PET imaging to understand the pharmacodynamics, what a drug is actually doing to your tumor and to your body, and measure that, and then help new drug development move forward. So this is a busy slide, but this basically emphasizes the problems that we have with assessing treatment response in prostate cancer that's in the bone. Well, prostate cancer tends to go to the bone, so there aren't soft tissue lesions on a CT scan where we can measure how big or small, how much it's grown, how much it's shrank. PSA is a nice measure, again, potentially for screening and detection, but it's not accepted as a surrogate marker going up or going down. Does that really mean the cancer is getting worse, getting better? We use it, but again, the FDA won't accept it to FDA-approved drugs. And I talked about all the problems with bone scans. It's not perfect. It's not quantitative. It's not measuring tumor activity. Sometimes it can look worse when the tumor's getting better, when you've actually killed the cancer cells. There's healing in the bone, and that actually looks worse on a bone scan. And things don't change quickly. And I've talked about all the problems with FDGPET and imaging glucose metabolism. This is not the most highly proliferative cancer. It doesn't grow the fastest. And for that reason, FDG, or glucose metabolism, is probably not as good. And again, I talked about the issues of obscuring the pelvic region because it's excreted into the bladder. There have been some studies that have been done that have shown that it seems to correlate a little bit with PSA when you're treating patients with chemotherapy. But the nice thing is that recently CMS says that they'll pay for up to 3 FDG PET scans for patients with prostate cancer. But the question is, who are those patients that should be getting that? I think it's probably patients that have, unfortunately, more advanced disease, because we've done some studies here that have looked at comparing FDG PET with AcetatePen. I remember this image is lipid metabolism, this glucose metabolism. This is a patient who you see the bone scan. PSA went down very nicely in response to 3 months of hormonal therapy. Bone scan didn't change. Well, the FDG PET wasn't sensitive enough to pick it up, but the acetate PET changed dramatically there. And so I think the key thing is that this is a hormone-sensitive patient. He just started on hormonal therapies. I think it probably FDG PET works better for patients that have more hormonally resistant diseases. I'm just going to run short on time here, so I'm going to get through the last few slides here. I want to show an example of how changes on PET scan might correlate with long-term outcomes. We ran a multi-center cooperative group trial here through Akron, which is the American College of Radiology Imaging Networks, looking at a new drug, Acetate, which not only potentially has effects in the prostate cancer, but also on bone turnover. And we wanted to see whether changes in response to treatment with Acetate, as identified by fluoride PET in the bone metastases, might actually correspond with long-term outcomes, meaning the time until the cancer gets worse on therapy. And it did. the interesting thing is it gave us kind of opposite results of what we thought. Instead of the scans looking less intense or better, the patients who did the best were the ones whose scans looked potentially the same or a little bit worse. And this just goes to show how you really got to think about what your imaging rate